Hello, my friends. Happy Friday. I'm really happy to be with you today. We're live. I'm here for your questions. The chat's on. So if you have anything for me, please feel free to drop right in. Otherwise, let's get out to your preset questions. We've got a lot of really interesting things to cover today. I think you're going to find it interesting. And if you see something that is right for you, feel free to chime on in and join the discussion. All right, first question. Hi, sir. Hello. Hello, sir, back. My husband has severe disc bulge in L4-5. The doctor suggests immediate surgery, but he is very afraid of it. Does it have any risks? He's only 35 years old. Well, time out. I have an MRI report next, and I want to go over that because on the surface of it, the question concerns me a little bit. A bulging disc is generally not a reason for surgery. Discs, remember, have a hard outer part and a soft inner part. And as the outer part loses integrity, it can stretch, and the inner part can kind of bulge. That is virtually never a reason to have surgery. And to be honest, oftentimes because they're very apparent on MRI, as doctors and as patients, we look at those things, but that's very rarely the actual cause of pain. So let's hold on a minute. Before we get into this further, let's look at the MRI and look at the MRI report and see exactly what we're talking about here. So this is the MRI read, which was provided by the radiologist. And as usual, you have a findings section and then an impression section. And if you don't read a lot of radiology reports, I can tell you the findings are where the radiologist is going to tell us what they see. They're just going to dictate, usually while they're looking at it, exactly what they see. Then on the impression section, they're going to tell us what they saw means. So now for us, let's look at this. At the L1-2 level, normal, 3-4 normal, 2-3 normal. At 3-4, there's a disc bulge, an annular tear, a broad-based posterior central subligamentous extrusion with a slight caudal migration. And this is on which side? Central, okay. Barely rimming about 9.2 millimeters. So that means that the outer part of the disc has ripped and the inner part has extruded out. But this is happening centrally. And oftentimes central disc extrusions don't really cause much problem. At L5-S1 level, it's normal, but at L4-5, we've got another disc bulge, an annular tear, a large posterior central bilateral paracentral extrusion with subligamentous migration. The spinal canal diameter is 6.3 millimeters. The diameter of the spinal canal is normally about 30 millimeters. So this is a very, very large herniated disc that is putting pressure on the spinal canal and causing quite severe narrowing. All right, well, you guys have heard me talk about this many, many times. There is a matrix of options for the treatment of herniated discs. And what you do depends on your functional neurological status and the severity of the pain. So we've got three things to choose between. It's not chocolate, strawberry, and vanilla for this one. It's wait it out, have an epidural injection, or the third option is microdiscectomy surgery, laminectomy surgery, decompression surgery. So those are the three options. How do we know which of the three is the best? Well, if the pain is bearable and there's no functional neurological deficit, then we're best to wait it out. That's number one. If the pain is unbearable, but there's no functional neurological deficit, then we're best to get an epidural injection. And in this case, I haven't heard anything about unbearable pain. And in fact, it sounds like her husband does not want to have surgery, so he's probably not super pain motivated. So that's not our option here. Case 3 is you're not functionally neurologically stable. You have a neurological deficit, which means limiting numbness or weakness, or as in this case, there's a disc herniation that's so large that it is functionally threatening all of the nerve roots. So this would normally be a number 3 situation where there's the risk of a functional neurological deficit or a significant giant disc herniation. So most of the time, the right answer for most people in this situation would be to have the surgery. Okay, so I got caught off guard by that question, but now that we've unpacked some of the evidence, I think that the recommendation of the local doctor that your husband should have surgery is correct. And now, long wind up, I'm sorry, but let me start to actually answer the question. The question is, well, what are the risks of that surgery? First of all, overall, the surgery is not nearly as risky as not having surgery. That's why surgery is being recommended. But when we consider the rest of it, let's look at it this way. There's a lining around the nerve roots inside the spinal canal, and that lining is called the dura. The dura is like a very, very thin fabric. It's like the lining of my coat almost. It's a very thin fabric, but the reason you have that lining in your body is it's watertight because the spinal nerve roots inside the spinal canal are surrounded by water. Well, during the surgery, if the surgeon were to nick that lining with a sharp instrument, then they could cause a leak, and that would be called a CSF, cerebrospinal fluid leak. And leaks of that type are one of the main risks of microdiscectomy surgery. Now, the truth is, if you get a leak, your surgeon's going to repair it. The long-term risk would be that the fluid could continue to leak out and cause headache, maybe even get infected and cause meningitis. I know that all sounds terrible, but it's incredibly rare. You're not likely to get a leak in the first place, and so it's really not something that I would say is a deal breaker. So risk number 1, CSF dural tear with CSF fistula, minor risk. Risk number 2 is that the surgery won't help, that they will take out all the herniated disc, but it's too late. You still have a neurological injury and you'll have continued pain. That's a risk. It's a fairly small risk. It doesn't change the reason for having surgery, which is to get rid of the risk of this giant disc pushing on the nerve roots. And so possible complication number 2, you don't get better, is really not a significant reason not to have surgery either. Risk number 3 would be that the surgery will be for nothing. They'll take out the herniated disc and more is going to herniate later. Again, that's not a risk anyone can really control, and it's unlikely to occur. And if it does occur, it doesn't change the reason we're here in the first place. So also not a significant reason not to have the surgery. You know, the risk everybody's afraid of and that people usually want to think about is paralysis, right? I mean, paralysis is the 800-pound gorilla. When you think about spine surgery, you think, well, could I become paralyzed? And the answer is no. You're not likely to become paralyzed from this. Now, this condition, if it's not properly treated and you have more disc herniation, you could get paralysis. You could get what's called the cauda equina syndrome. You could get loss of bladder control, loss of sexual function, and permanent numbness in the private areas, everywhere where your body touches a horse's saddle, if you're riding a horse. So yeah, there are some significant risks of not having surgery. There are some risks of having surgery, but on the whole, I would strongly recommend that your husband follow his doctor's advice, have the surgery. That's the safest way to remove the risk to his nerve roots and give him the best chance of going on and leading a normal life. It is true he's only 35 years old, but that's why it's so important that he not be left with a neurological deficit at a relatively young age that he's going to have to deal with for another 40 or 50 years. No. So surgery is the right way to go in this case. Thanks for submitting the question. Please follow up and let us know how it goes, whether he has the surgery and what happens to him. All right, you guys, I'm checking the chat and I don't see anybody yet. So if you're out there and you have chat questions, drop them in. I'm looking for you. I want to talk to you. So feel free to drop them in and let me know what's going on. Next question. Last April, I hurt my back. I think from lifting boxes of books at home. Ugh, no good deed goes unpunished. I was working as an x-ray technologist, a mammography tech in a hospital. I had numerous stabbing pain from the anterior part of my left thigh to my left knee to the interior side of my thigh. So bad I couldn't sleep. So the nerves in our legs are arranged in what are called dermatomes. Dermatomes are the areas of our skin in our legs that are innervated or subserved by a certain nerve. The nerve that goes from the front of the thigh to the inside of the thigh is the L3 nerve root typically. So we'll be looking for in this story, because that's where the pain is there something going on with the L3 nerve root? I had an MRI June 30th and it showed a left L23 neural foramen lesion measuring 7 by 10 by 12. Either a foraminal disc sequestration with venous congestion, inflammatory changes, or a schwannoma with a cystic component. A second MRI with contrast on a 3T machine was inconclusive. I had an injection in July, which immediately took away the numbness and greatly reduced the pain. I did physical therapy. I'm walking 3 miles a day. However, it's January and I can no longer peridist, some typo for just a half hour. Airplane out of the question. If I overdo it, I get so much leg pain and a dull increase in my back. Will it eventually go away and get better on its own? Should I consider a second injection, or will I need to consider a microdiscectomy surgery to get better? I live alone. My kids are grown and busy. One is in medical school. Ooh, congratulations. And so I worry about how I would do with recovery from a surgery. I'm 57-year-old and otherwise in good health. Thank you, Martha. Martha, thank you so much for submitting this question. So basically, it's a herniated disc, but the MRI shows such a large finding that it could also be a schwannoma, which is a type of a tumor. The odds are very, very strong that it's a herniated disc. It's just if you look at how common herniated discs are versus how common schwannomas are, 99% of the time it's actually a herniated disc. One way to tell the difference is to wait and get a follow-up MRI, because tumors get bigger and discs usually get smaller. So one way to know the difference radiographically would be to wait it out and see what happens. However, having said that, you're now more than 3 months out. In fact, you're 9 months out. You've got a significant sciatica. It's in the distribution of the L3 nerve root, which is what the L23 disc affects. And so I don't think there's any question in my mind that of your usual 3 options in the matrix, wait it out. Well, you did that. It didn't work. Have an epidural injection. Great way to relieve pain for about 100 hours. We're 9 months out. Another 100 hours of pain relief is not the issue here. So epidural injection is not an option. Or microdiscectomy surgery. It's funny because surgery is usually not the answer, you guys. It's very rare that microdiscectomy is the answer, but in both of these first 2 questions, the answer really is microdiscectomy surgery. Now, what if it turns out to be a tumor and not a disc? Well, while they're there, the surgeon can remove it. So I would recommend, normally you can see a neurosurgeon or an orthopedic spine surgeon. In your case, Martha, I would recommend a neurosurgeon and one who would feel comfortable in the unlikely event that this is a schwannoma. They could remove it and that would be the end of the tumor. If it's a disc, that'll be the end of that as well. So 2 out of 2 surgery. Gosh, that's very unlikely, you guys, but that's the way it is so far today. Next question. Hello, Dr. Lieberman. Hello back. Thank you so much for submitting your question by video ask. I just love our new service. You can enter by text, you can enter audio, or honestly, the one I would prefer, just hit record and enter your video. I would love to see your face and see, I get so much information and I feel like I can give you such a better answer if you submit the question by video. So please feel free to do video submissions here. But this one, I'm happy to get Alex's question by text. Hello, Dr. Lieberman. Hello, Alex. I hope this message finds you well. Yes, it does. My name is Alex. I'm 27-year-old male. I wanted to get your opinion to see if surgery is the right call for me. I had an MRI done January 19th and was diagnosed with 2 large disc extrusions, 16 millimeters, at L5S1. Yay. Yeah, that is a big disc. Sorry about that, big guy. I'm sure that's very painful. The injury happened on December 6th while moving and twisting at work. My symptoms were severe radiating pain from the glute down to the foot, numbness in the back of my thigh, the left side of my foot and heel, not able to walk on my tippy toes, all this on the left side, nothing on the right. Fast forward to today, January 20th, my symptoms have improved quite a bit. The numbness in my thigh has mostly faded. The pain in my calf has gone from an 8 to 9 to a 2. My foot still has numbness on the left side in my heel. I can't walk on the tips of my toes. As far as back pain, I only get pain when bending or sitting too long. I guess my fear with the weight and C approach at this point is the fact that I can't walk on my tiptoes, and it's quite a large herniation. If I decide not to do surgery, that'll go back to work and I'll just re-aggravate the injury, and it would take my body quite some time for a large herniation. Thank you for answering. Yeah, another herniated disc question, and again, we've got our 3 matrix responses. Wait, hurry up and wait, which is what Alex has done so far, and it's been working. He's gotten a lot better. The pain is largely dissipated. He does have a little bit of functional weakness. When he tries to walk on his toes, the gastrocnemius muscle is the muscle that contracts and allows you to get up on your toes. And the gastrocnemius muscle is innervated by that L5 and the S1 nerve roots. And those are the roots that are being affected by this herniated disc, in particular the S1 nerve root. So Alex's question is, option 1, wait and see, didn't work. Option 2, epidural injection, doesn't make sense. 100 hours of pain relief when we're, 2 months into this. Option 3, microdiscectomy. This gets into the question of what really is functional weakness. And the reason it's a difficult question to answer is it really does depend on the individual situation. So Alex is unable to walk on his toes. Now, if you were a tightrope walker, that's a huge problem, right? You have functional weakness because you're not able to get up on your tippy toes and maintain yourself on that rope. If you are an accountant and work at a desk, then a little bit of toe extension weakness, flexion weakness, is really not a functional problem. So Alex, my response to you is, it really depends. I would say to yourself, ask yourself this question. It's not likely to get worse. So if I had this degree of weakness for the rest of my life, would that really be a problem for me? If the answer is no, not really, then you should wait it out. If the answer is, yeah, this amount of weakness, it's a problem for me, it's going to affect what I do, then the answer is you should be pursuing microdiscectomy surgery. I understand your concern is, well, what if I go back to work and I have another herniation? Having surgery doesn't change that risk, really. When you have surgery, you can always have another herniation as well. So it's definitely an interesting case, and definitely one that you can only come to the right answer by asking yourself the right questions. So ask yourself that. If I was like this for the rest of my life, would that really make a difference? If the answer to that question is yes, have surgery. If the answer is no, don't. All right. This is a copy of the MRI. This is Alex's MRI. And in this image, which is a little bit hard to see here, you can see that this is a normal disc that ends flush with the back of the bones of the vertebral body. But this is the herniation right here. That's the herniation right there. So yeah, same answer. Definitely same answer. All right, hey you guys, I still don't see any questions. I'm here. So remember, if you have anything live for me, drop it in right now. I'll be able to answer your question right now live on the air. Let's go to the next question. Oh, this is a video submission. Thank you so much. Let's hear it. That's the herniation right there. So yeah, same
Hey, doctor.
answer.
Good evening.
Definitely same
So
answer.
this is Pradeep from India side.
All right, hey you guys. I hope you guys can hear it, but I can't. Let me grab my hold on a second. I need to get my earphone in so I can hear this. Yes.
I don't have pain. I have the heaviness and stiffness and muscle spasm, you can say, at my low back area. I can't sit for more time, and even I can't drive my car for more. I can't stand at the same place for more time. Okay. My main concern is like anytime I can feel a jerk at my low back. Actually, it was happened in the gym 3 years back while my doing my squat exercise, and the weight was very light, don't so heavy weight. And from that very day, I've done so many treatments, took so many medicines, chiropractic treatment also. But all the treatments are like not work for me. These days, you can say my body is very flexible. My spine is very flexible. I'm last from 3 years. I'm doing yoga, exercise. I can perform any pose of yoga. I can bend forward, I can bend backward, I can bend side, any bending I can do very easily. I can touch my, you can say, toes without bending my knees in a very easy way. But still, with this flexibility also, but still I'm not happy because my you can say it's a feeling of heavy stiffness and heaviness my low back and hips area. Sometimes I'm feeling numbness at my legs also. Uh, when I get my, you can say MRI 3 years back, that first MRI shows restoralysis of L4, L5. Okay, and all doctors told me that my reports are okay. And few months back, I go for a new MRI, and that comes out to be DDD at L4, L5 level. Okay, there is no mention grade of what grade I have at DD level, but they mentioned only disc degenerative at L4, L5 level. But still, I have shown my report to all the surgeon over here. So many surgeons, so many orthopedic surgeons, neurosurgeons. All the same wording of all the doctors is like your reports are quite okay. There is no any issue with your structural issue you have. Your issue is in your mind. So try to you can say fresh your mind and leave this that you have any problem in your spine. But still, I am worried about this because I can't do my daily activity. So, doctor, kindly guide me what sort of thing I have to do for my proper, you can say, cure. Thank you very much.
Oh, very interesting. Pardeep, thank you so much for submitting your question by video through the video ask in your phone. I really appreciate you lining it up that way. And so if I understand the situation, Pardeep, like a lot of people, he doesn't have actual pain, but he's got something going on that feels so much stiffness and so much tenuous that it's worrying him and it's limiting his motion. He's tried very hard to do yoga, which is a great form of conservative care and core strengthening for back problems. And yet, several years later, several years into this, the problem persists. He's seen multiple doctors, and no surgery of any kind has been recommended. And so he's left just wondering, hey, what the heck's going on? They're telling him that it's basically all in his head. And they did submit this, he did submit this MRI. And what we've got is he's taken a picture of the MRI. Here's the sequences. This is the spine, the lumbar spine. Here's L5, 4, and 3. And we see that the bottom two discs are relatively dark compared to the top ones. But Pardeep has a very nice curve in his spine, a very nice wide spinal canal, and the rest of that looks pretty much normal. When we look at the second level, it ends here. Then we start the third sequence here. There's, I'm trying to see in this, yeah, so right there there's what looks like high signal in a facet joint, and that's also going on right there. Let's see if I can blow this up enough that we can get a better look at it. Yeah, I just want to make sure we don't miss anything on this MRI. Yeah, I see why they're telling him it looks normal. It does look pretty good. The MRI does show significant swelling of the facet joints, which are the lumbar facets there. But other than that, that's about the only abnormality that I see. And so I would say that it is likely that what you have, Pardeep, is arthritis of the joints of the low back. Remember, in our model of the spine here, here's a guy facing you. And now if we turn him around, we can see the joints of the spine here. And those joints are called the facet joints. When they hurt, you do get a feeling of stiffness. And the best treatment for that is to undergo yoga and maintain your activity and do other types of flexibility. If this becomes more, so where you are right now is safe and healthy and you're doing the right thing for your condition. If it should not worry you any more than is helpful to you. So, you know, emotions, we can't control the arthritis in our backs. Everyone has facet joints and we can't control what kind of shape they're in. We can't control this injury that happened in the gym. When I first heard about it, I thought it was a disc injury, but I don't see any disc abnormalities on the scan. So it was probably an injury to one of the joints or the ligaments. You can't turn back time. We can't control that. We can't change that. The only thing that we have absolute control over is our reaction to the things that we're feeling in our bodies. And this is where it's extremely important to remember that while we are in our conscious minds always thinking about trying to understand what happened to us and looking at our past, and we are historians by nature, our brains are not historians, our brains are predictors. Our brain is always trying to think of what's going to happen in the future. And your mind, Pardeep, because you had this experience, it's associating all these things you're feeling in your back with a bad and uncertain future. And I'm here to tell you we can be very confident based on the MRI and based on the history that you have shared with me that your future is not only not bad, it's good. It's very likely that if you continue your flexibility and you continue your strengthening, that you will continue to do better and better and better, and that this event, whatever it was, is not likely to happen again. And if it does happen again, you can deal with it. You can get another MRI. You can see if there's been any change. You can adjust your yoga to try to strengthen different moves and listen to your teachers. So there's a lot that can be done and a lot that can happen going forward. But for right now, today, there's nothing new that needs to be done. If it gets worse, that's a change that will have to be reevaluated. Call me back and we'll go over it. But for where we are right now today, you're okay. Your MRI is reassuring, and you should give this a little more time and see how it goes. So I don't think you're crazy, but I do think you should withdraw energy from this and put it into other parts of your life and see if you can make progress in other areas. All right, let's see what else we got. Oh, you guys don't want to talk to me? I got no live questions. Come on. Let me know what's going on. I'm here for you. I want to see what you think. Remember, if you have any chat questions, throw them in. All right, next question. Oop, I put this up so much I can't read it. Hello, my name is Emanuela. Hello, Emanuela. I'm 28 years old. It's nice to meet you. I'm working as a nurse in Romania. Oh my gosh, Romania. And a nurse. Good for you. It's always lovely to talk to a nurse. I have a herniated disc in my lumbar area from lifting heavy weights at the gym with improper form, and I've been struggling with back pain for more than 2 years. Oof. So she had a disc injury while weightlifting, and now she's got back pain. In the last 6 months, the pain is worse, and I also get tingling on my right leg. I want to live a pain-free life. I did physiotherapy and physical therapy. It only worked for a short time. Thank you. All right, so the problem is back pain. There is some numbness and tingling in the leg, but no weakness and no numbness. I don't hear, I've got one image of an MRI. Hold on. And that's here. And here we've got, so this MRI is shown a little bit different from most of the time we see them. It's like she's laying on her stomach. So these are the bones of the spine here, and these are the discs. And oh my goodness, these are beautiful, healthy discs. Wonderful, 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 wonderful goose. So this one, see how the color is dark? And where the disc should end flush with the back of the bone, it's protruding out a little bit. This one, same thing. So there are annular tears in the L4-5 and the L5-S1, which are causing degenerative disc disease. I've only got one image here, so I can't see the joints, but there's also a little bit of signal along the interspinous ligament here, which means there's probably an element of chronic strain in the low back. If you watch my playlist on low back pain start here, it tells you that the very first thing that you must determine when you have a back problem like this is, what is the source of my pain? What is the source of my pain? Because until you know what's wrong, you don't know what to do about it. Until you know what's wrong, you don't know what to do about it. The thing that's complicated about the back is these changes on the MRI, these old annular tears in the discs that happened in the weight room years ago, they're going to be there forever. Now, they may or may not be the actual source of the pain. So we have to compare up the kind of pain we're feeling with what we see on the MRI to arrive at a good treatment plan. Now, based on the description of the pain, this is primarily back pain without a strong radicular component. And primary back pain is from one of two things. One is the disc itself can hurt. That's called discogenic low back pain, sometimes referred to as degenerative disc disease. Or the joints of the spine. Remember these guys, these facet joints? They can be painful as well. They hurt in different ways. If you have a painful disc, it feels like a knife in the back. It's right in the middle. It's worse when you're sitting down, and it's there pretty much, it's not necessarily made worse with activity. It's a knife in the middle of the back. That's not what she's describing. She's describing pain that sometimes feels like it radiates into the leg. She's describing what is much more typical of facet joint pain. Facet joint pain, you know, I've seen this movie before, having heard thousands of people describe it to me. It's off to one side, there's a cramp in your back, it feels like it's in your hip, it radiates to your butt, and it often burns or tingles in the outer thigh. And it's very, very common if you have a torn disc on MRI to then go on to develop years later facet joint pain. In fact, I want you to think about your discs like shock absorbers. So you're going through life and you're walking, you're jumping, you're skiing, you're riding, you're falling off your bike, right? All these things are happening to you, and your spine, your discs are your shock absorbers. But now in the gym in Romania, she tore the disc. And so their shock absorbers are gone. So what happens? Those joints are having to, every time she walks out of her place and down to the hospital for a shift at work, every time she does anything, she's getting shock onto the joints. That causes an accelerated wear and tear, and that causes facet joint pain. That's most likely what she's describing. So I think you have facet joint pain. The next step for that is to see a pain management doctor who can do a medial branch block. And if that is successful, to go on to radio frequency ablation, RFA. So please, please go back to my low back pain start here. Watch those videos. Make sure I've got this right, that this is the kind of pain you're having. And then watch the radiofrequency ablation and facet joint pain playlist and learn what you need to do to find the right doctor to get that treated. You're going to do well. We can make this go away. You just need to get the right treatment for it. All right, thank you. We got some questions. This is from Lori Hill. Hi, my name is Randy. It loaded as my wife. Oh, yeah, welcome to the modern world. I have a herniated and major sciatica and numbness in my foot. I'm going on 6 weeks. The pain never gets better. I recently had the epidural injection. What's the next step after the shot? I worry that the numbness in my leg and foot will stay numb if I don't do something soon. I'm starting to freak out. Understood. So you've got a herniated disc with sciatica, and you've got those 3 options: wait it out, have an epidural injection, or have microdiscectomy surgery. If the pain is unbearable, which it sounds like yours was, then you get epidural injection. If you have a functionally limiting numbness or weakness, then you're a candidate for microdiscectomy surgery. So you had the epidural injection. That starts the calculation over. Now we're back to the same point. Do we continue to wait it out? Well, not if there's functionally limiting numbness or weakness or unbearable pain. Sounds like the pain is still pretty much unbearable. Do we get an epidural injection? Epidural injection is great, but it's a temporary form of pain relief, so it's not appropriate if you have functionally limiting numbness or weakness. So long story short, Randy, whose wife is Lori Hill, it all comes down to whether you have functional numbness or weakness. So you're afraid, hey, I don't want to have permanent neurological damage, and you're exactly right. If the level of numbness or weakness that you have right now, if you had that forever, and that would be a problem for you, then your best chance of getting rid of it and shortening the length of your pain would be to have microdiscectomy surgery. If you have functionally limiting numbness or weakness, then the best chance is to have microdiscectomy surgery. Understand, Randy, that we did these studies. Doctors did this. We had a guy come in, Randy, flip a coin, surgery. Next guy, flip a coin, wait. Next guy, flip a coin, surgery. And we compared these 2 groups at 2 years, and they were the same. So everyone's like, oh, surgery doesn't do any good. Oh no, surgery did a ton of good. It helped people get better immediately, way faster, but it didn't change the 2-year outcome. So that's why we say today, look, if you're kind of making it through this and you're 6 weeks in, but these often go to 12 weeks before they're resolved. So if you're kind of making it through, then I would say wait. If your pain is really more than you can bear, but you're not worried about the numbness and weakness, then I would say have a second epidural injection. If you're like, oh, I'm getting worried about this, and that's kind of the vibe I'm getting from your comment. I'm getting worried about this. I would be bothered by this numbness or weakness if I were to have it forever. Then the answer is definitely microdiscectomy surgery. If you need microdiscectomy surgery, you want to have it in a minimally invasive fashion. You can ask for a reference from your pain doctor or your primary care doctor, or you can look online, or you can call us, because we help people find minimally invasive neurosurgeons and orthopedic spine surgeons to do this kind of work. One real great development over the last 5 years or so, almost 10 years now, is what's called a microdiscectomy with a tubular retractor. So instead of making a big incision and going down there and drilling off your bones and taking out your herniated disc, they make an incision that's about 1/2 inch. They put in a tube and they do the whole operation down that tube looking through a microscope. That's called microdiscectomy, micro meaning microscope, with a tubular retractor. Some surgeons would call that metrics, METRX. That's the name of the most often used brand of tubular retractor. That's the guy you're looking for. The surgeon who can do it either endoscopically or with a tubular retractor. So, and by guy, I mean surgeon. Could be a woman too who does just as good. So that's the person we're looking for to do your surgery. All right, Randy. How safe is the surgery? It's extremely safe. the microdiscectomy surgery, the biggest risk would be damage to a nerve root. It's already, if you're having surgery, your nerve root's being damaged. So you're kind of trading a lower risk for a higher risk. So not that significant a risk. There is this nicking of the dura and causing a spinal fluid leak. Uncommon, less than 10%, but definitely does happen. You may have persistent pain. You may have a recurrent herniation. But 85% of patients who had microdiscectomy surgery are glad that they did. And so there's a very high probability that you would have a good or excellent outcome. Everyone talks so bad about back surgery. Not everyone. The people who do well will tell you over and over that they couldn't live without it. So we don't go based on popularity. We go based on the numbers and the literature and the reports. And in this case, if you have functional numbness and weakness, I don't care what everybody says, you need surgery. Thank you, you've been so helpful. Oh, you're welcome. And feel free. By the way, you definitely should send us go to our bestpracticehealth.tv, send us a video question, or at least upload your MRI. Take a picture of your MRI on your phone, send it to me so we can see it and comment on that and make sure it looks like the kind of disc that surgery would be necessary for. I can give you a better answer if I get a better question. So please feel free to do that. Hey, and Randy, follow up. Let us know what happens, will you? Drop us a line on bestpracticehealth.tv. Love to know what's going on with you, and I wish you the best, my friend. Good luck. And tell Lori you'll be better soon. Brandon Go. Hey, doc, thanks for replying to my question. Yes, I have a surgeon, and I've tried epidural injection. The pain dissipated for 2 days, the procedure, and then it came back. I think the shot just basically numbed the pain. Yeah, but that's also, Brandon, that's what epidural is supposed to do, right? It doesn't change the underlying. It's like when you have an epidural to have a baby. The epidural didn't change the fact that you had a baby, right? The pain went away because you had the baby. So it's just a temporary form of pain management. I've been doing physiotherapy for 6 months. That's too long, right? 3 weeks is about the right amount of time. If you don't get better after that, it's probably not going to help. My mom seems adamant on surgery, and she says it's something that might affect me forever. And it should be done if I'm unable to tolerate the pain or unable to perform my day-to-day activities anymore. Yeah, I mean, but I would agree with your mom on that. But that's not a judgment. These things are sometimes so painful, they're not tolerable. And the only person who lives in your body is you. So that's your decision to make. If you reach the point where you're like, hey, this is more than I can bear. And people often say to me, well, how do I know when I'm at that point? You know. You know because you're like, ooh, I can't live like this. And if that's what's happening to you, then that's not weakness. That's not anything. That's smart to act and make sure you get the care you deserve. If I go for the operation, I'm afraid of the risk as well. Other than surgery at my stage, is there any other alternative? For a herniated disc, no. There isn't. The herniated disc does get better on its own. Epidural injection is temporary pain management. Some people have tried stem cell injections. It's really early. I think the verdict is still out on that for a herniated disc. So really the only other episode is to wait it out or take medications. Anti-inflammatory medications are definitely going to be helpful. Does physiotherapy still have an impact on my healing? No, it's not going to help for this. Does traditional Chinese medicine work? Yeah. Acupuncture is some type of an anti-inflammatory response, as far as we can tell. The Chinese may interpret it differently, and they're certainly entitled to because they're the experts. But the way most of us in the West see it today, which is not to say we're right and they're wrong, it's just to say if you translate it into the way that we look at the body, it seems like the needle piercing the body causes an anti-inflammatory response, anti-inflammatory release, just like taking an anti-inflammatory pill would do. And it kind of seems like there's no magic, right, in this stuff. Our bodies are real. They're our bodies. So that whether you get that anti-inflammatory response from a needle through acupuncture or from an oral agent or from a steroid injected as an epidural, it's all still just anti-inflammatory response, and nothing wrong with that. How much of my mobility will be affected after the surgery? None. You will not have any change in your long-term mobility as a result of microdiscectomy surgery. Will the surgery impact my sex life? No. There are spine surgeries which can leave you impotent. This is not one of them. Sex and disc herniation sometimes get tied up in people's minds because really, really large disc herniations can cause the cauda equina syndrome, which can affect sexual function. However, they have to be ginormous discs to do that, and you almost always have urinary retention and saddle anesthesia. That's numbness anywhere a saddle would touch your body in that syndrome. So if you don't have just a massive disc herniation, you don't have cauda equina syndrome, you don't have to worry about sexual function. And certainly the surgery is not going to alter that. There are questions, these are the questions pondering in my head. Yeah, I mean, it sounds like you're going about it in exactly the right way. As I said earlier on the show, our brains are predictive organs. It's your brain's job to try to predict what's going to happen to you, so what's the right thing. And when you throw in really severe pain, that gums up the prediction works pretty fast, doesn't it? I mean, it's really, it makes us desperate. It makes us make bad decisions. I really get the feeling you're going about this in a really good way, that you're looking at it holistically for your whole body, planning for your future, and basing it on your actual risks. So I think you're doing a really good job. Emmanuel says, thank you. You are welcome. Thanks for listening. I really appreciate you being here today. All right. Here's the next question. Would a doctor use a posterior? Oh, wait, I'm sorry. I've got this. Why would a doctor use posterior hip replacement? My sister had a replacement in 2019 and had a horrible surgical experience and a long recovery. She ended up spending weeks in the hospital. That doctor retired later that year. The following year, our 91-year-old mother had a hip replacement. Different doctor with an anterior approach, was up and walking with a walker in no time. Why would anyone do it the old-fashioned way? Oh my God, I love this question. So yeah, it's dramatic, right? Your sister had 2 weeks in the hospital. Your 91-year-old mom was up and walking right away. Approach matters, people. It matters a lot. The anterior approach is one of the minimally invasive approaches. The old posterior approach is a legacy approach. And the question is, why would anyone do that? And the answer is because that's all they know how to do. They were trained to do that. The anterior approach didn't exist when that old orthopedic surgeon learned to do these operations. 95% of the operations are done the wrong way. And I mean, all I can say is that's not happening to anyone who watches this show, because we're telling you the right way is the minimally invasive approach with robotic assistance in an outpatient center with ceramic implants. I mean, there's a lot of details to this stuff. You got to do your homework, but it's worth it because it makes a big difference in how you turn out and how you do. Katie Girl, if medial branch block doesn't work, then why go forward with ablations? Oh, thank you so much. Hello, and thank you so much for the question. You should not go forward with ablations if medial branch block doesn't work. Let me just put this in context for everybody. So the facet joints are a common source of pain, and one treatment for that pain is radiofrequency ablation. Well, in radiofrequency ablation, the nerves that go to these joints are burned, and the burning takes them offline for an average of 10 months. Well, we got to make sure, it's complicated, right? We want to make sure that the pain really is coming from the joints the way the doctor and the patient think. And so the way you do that is you do a test, and that test is called a medial branch block. It's a temporary numbing of the nerve roots, and its purpose is to find out if you should have radiofrequency ablation. So if you're in pain, you get the block, the pain goes away, and then the pain comes right back, then that's a positive test, and you should go on and have radiofrequency ablation. If you get the block, the test, and you didn't get temporary relief, that's a negative test, and you should not go on and have radiofrequency ablation. So very, very important question, Katie Girl. Thank you for asking it. All right, guys, that's all my questions for today. I really appreciate you being here. And thank you for your online submissions. Thank you for your video asks. And I am so excited to be with you next week and do it all again. For Best Practice Health, I'm Dr. Dan Lieberman. Have a great week. Take care of yourself. Take care of each other. Be safe. And keep submitting those questions. We'd love to answer them. Talk to you soon. If you have a question you would like answered on Best Practice Live, click the link to our website and complete the submission form. The more information you can give us, the better we can answer your question. So please contact us and we can walk you through uploading your imaging to a secure server. Please like and subscribe to our channel to stay up to date with information about your spine and joint health.